So the first case is EP, who is a 68-year-old with COPD who needs a total hip replacement. She notes snoring and poor sleep when she's being evaluated for her hip replacement, and an Epworth Sleepiness Scale score of 9. And she's noted to, in addition to her COPD, have comorbid hypertension. Her most recent spirometry is seen here. She has, as you can see, mild obstructive lung disease with no significant response to bronchodilators. So a polysomnography is ordered, and the baseline data on the polysomnography shows she has very quite frequent apneas and hypopneas with an apnea-hypopnea index of 128 events per hour. Her lowest oxygen saturation is 79%. And she actually spent a good amount of the time during the sleep study, the baseline portion, with her sat below 90%, 42.7% of time during the baseline portion of the study with a low oxygen saturation. So it was performed as a split night study. So the second part of the night, they put her on CPAP and a titration occurred. And at a CPAP pressure of 10, they were able to drop her residual sleep disordered breathing index to 3.4 events per hour. Now here is a picture of her sleep study. We call this a hypnogram. And to just take you through this briefly, the top box here is sleep. And so wake, REM, non-REM level 1, non-REM level 2, non-REM level 3. The next part of the hypnogram shows body position. So start out on her back, move to her right, a little bit of time on her left, and then to her back for the rest of the night. As I noted, this was a split night study. So she was put on CPAP at this point, and you can see the progression in CPAP pressures. This, of course, is her oxygen saturation, starting at 100 down to 60%. Heart rate, snoring, you can see there was some snoring going on pre-CPAP, and the breathing events. So the predominant number of breathing events were obstructive hypopneas, and you can see those here. The other thing I want to point out is, as I mentioned, she had a lot of oxygen desaturation, both associated with hypopneas and even kind of a low sat in general, probably due to her underlying lung disease. And then you can see as the CPAP pressures increased, the degree of oxygen saturation improves, and when she gets over here to the pressure of 10, her sat is much improved, and there's no longer any obstructive breathing events.
So Nancy, if we can just go back to that last slide, a lot of respiratory physicians look at these hypnograms. Actually, a lot of respiratory physicians look at oxygen saturation in the AHI. So do you think there's something more we should be looking at besides oxygen saturation and AHI, which seems to be what a lot of us are obsessed with in this hypnogram? And how important is it for us to look at these hypnograms?
Yeah, I think, so when I get a sleep study from an outside provider, it's the first page that I look at, because the narrative page that will give you the AHI, sure, but it really doesn't give you the whole story, right? So the AHI is obviously, you'd like to see when the events were occurring. And in addition, you'd like to see what type of oxygen desaturation they're having with these events. So again, for this particular patient, and the other thing I would mention, and this will come up more as we get to the second case, you want to see how many different levels of sleep did they go through on the baseline. So as you can see, one of the problems with split night studies is that if a patient has severe apnea, you want to get them on CPAP and get them titrated, but what will often happen in a split night study is they won't go through REM sleep. And so you can see she does have a REM period here. This is the black thick line here, but she doesn't have REM in the beginning. Sure. And so you would suspect, based on her severe sleep apnea and her underlying lung disease, that in REM she would have done even worse. Sure. So I think those are the highlights that you look at on the baseline. And then obviously, as I said, in her, while she doesn't actually have that, what I would say, severe oxygen desaturation, because, sometimes we'll see saturations go into the 60s and 50s and even lower sometimes. She has consistent oxygen desaturation, but she's kind of hanging, her desats are kind of hanging in the 80% range. The other thing I'll point out is, over here, when she's on CPAP and REM, you can see she actually does pretty well. I had to split the screen so you can kind of see the whole thing together.
Right.
But she does have a few hypopneas over here in REM. And that kind of precipitated the increase in the pressure. So you want to make sure, ideally on a CPAP titration, that they go through REM sleep to make sure you've gotten the optimal level of CPAP.
Please go ahead.
Okay, so she gets put on CPAP. She has her hip replaced. And as often as the case, she has some struggles with the CPAP, but she agrees to use it and has to change her mask a few times, but she finally finds one that works. And she comes back to clinic after she's been on the CPAP for 3 months. Her oxygen saturation in clinic is, on the lowest side, but okay, 93%. Her Epworth is a bit better, improved by 2 points. And if you look at her CPAP adherence data, she missed 3 out of the 90 days, but her average use is 5.5 hours. There's not much leak from the mask currently, and the residual AHI is at 2.8. So you feel pretty comfortable that she's doing okay on her CPAP.
So Nancy, one more thing on that slide was excellent compliance. I mean, pretty decent compliance. Yet I noticed that, her pressure requirement is 10 centimeters. Now, this is a little odd. We've normally seen high AHIs, higher pressures. Any thought there?
Yeah, so I think in this particular case, remember, she has kind of borderline oxygen saturation. So she's kind of hanging right on the curve of that oxygen saturation drop off.
Sure.
And what you'll see a lot of times is people have, particularly people with lung disease, will have maybe a high AHI, but not that, as you noted in the slide before, not real severe oxygen desaturation. So she has a lot of events. Sure. With narrowing of her airway, and drops off that 4% quite frequently. Right. Really, she doesn't require a lot of pressure to keep her airway open. And, it's kind of average pressure. So,
sure.
So I think it has to do in this particular case because of her underlying lung disease.
Lung disease. That's what I was thinking. Probably the underlying lung is the larger reason for that lower pressure requirement. Please go on, please.
Okay. So she gets her hip replaced. She kind of gets lost to follow up, but comes back 4 years later. And her lung disease has progressed in such that now she's having to use oxygen during the day at 2 liters per night. 2 liters per minute. And so we go ahead and get her CPAP data from her machine. And this is a picture of her download. Now it's a lot of data to digest.
Right. Can you explain it as simply as possible? Because I find it a very complicated slide, but for our audience.
It is, but I guess for me, having looked at thousands of these over my life, it's like, oh yeah, that looks great. So I'll take you through it very quickly. So on the first page, I kind of put several pages together. But on the first page is the hours of usage. And so each bar represents a 24-hour period. So for example, if a patient would sleep 5 hours one night and take a 2-hour nap, it's going to show up on here as 7 hours. Sure. So this is cumulative sleep time. And the black line here is 4 hours. So in the US, insurance companies require that patients use their CPAP at least 4 hours or they'll take it away from them. Sure. So this black line is there. But in her case, you can see she does pretty well. And so most of her bars are green, which means that she used it at least 4 hours every night. She does have one red bar, which means that particular night she used it less than 4 hours. And then there's one where a bar is missing, which means that night she didn't use it at all. So again, pretty good use. And probably pretty consistent with that 5.5 hours she was doing before. When you go to the next page, you'll see actually when they put the machine on and when they take it off. And so it gives you, hours down here, hours of the night or day. So 0 being midnight. So, she's consistently putting it on around midnight and waking up around 6 or 7 in the morning. This night she put it on a little early and then had an awakening and stayed awake for a while, and then put it back on. And this fraction over here is the amount of time that the machine was on and at pressure divided by the amount of time the machine was running. So you can see most of the time it looks like she put it on and wore it all night and never took it off. There's an occasional one where there might be a minute or two here where, maybe he or she, you can see there's a little black line there. So that means that she was wearing it. She got up, maybe used the restroom, kept it running, and then put it back on and it was back at pressure. So it's, 618 over 621. Just took a couple minutes, left the machine running. So that's that. And this is very helpful to kind of see, it's almost like an actigraphy. You can kind of track patients' time that they're using the machine, if they're taking naps, if they're night owls, all different kinds of things you can glean from this. Very helpful at times. The next page on the report just gives you information about how well the machine is functioning and what the pressure settings are. So her pressure is at a fixed pressure of 10. So you can see she's on 10 all night long. And then the machine has a flow sensor in it, and it tells us how often the patient's having any breathing interruptions. And so again, this is across that 90-day period. Each little section here represents 1 day. And overall, she's doing quite well. She's having, no periodic breathing. She's not having she's having very few apneas, occasional hypopneas, RERAs. And then this even looks at snoring and flow limited breathing. That's what FL stands for. Sure. So over this 90-day period, the machine estimates that her average breathing index is 2.4 per hour, which is similar to what she was when we saw her 4 years ago. Right. So what we aim for this number to be is less than 5 per hour. And then the last page of this report gives you information about leaks. So if the mask is leaking, you'll see some data here. You can see she has very little leakage from the mask. And then this is information about her humidifier settings.
What is an acceptable leak?
This is a really nice summary, and in this particular case, a very adherent patient. There's lots of information that you can glean from these reports, and I would encourage people, if they can get them, to look at them.
And what would be an acceptable leak when you look at the leak graph?
Yeah, so the way this is a machine that's made by Philips Respironics, and what they will call an acceptable average percent leak is less than 10% per night. So just going back, remember, she's lost the follow-up. Right. She's using her PAP, and we can see it looks pretty good. She's on oxygen during the day now. And so it looks like this all looks great. So what would you do next? Would you do anything different, or just say, you're doing great, see you later? So the CPAP information is great as far as looking at disordered breathing events, but it doesn't inform you at all about oxygen levels. Sure. And as you know, as a pulmonologist, right, that sleep can be a stress test for people with lung disease, just like exercise test might be. And so in cases where we know patients have hypoxemia, it's always worthwhile to check an overnight oxygen test on them, particularly in this case where we know her oxygenation has definitely gotten worse over time. Sure. So we ordered an overnight oximeter on her while she was wearing her CPAP machine. And so here's the result. And you can see she has pretty dramatic oxygen desaturations during the night, even while on CPAP. So at this point, you have a couple options. You might bring her back into the lab, which probably most people would do, just to monitor her and see if CPAP plus oxygen alone is going to be appropriate, or it may benefit from non-invasive ventilation.
Sure. And when you bring them back into the lab, Nancy, do you actually check the flow rate the whole night? You have your technician checking the flow rate every night, or you just set it at 1 liter per minute and get your data the next morning?
Right.
How do you decide?
We would bring them back and do in this case, probably do a full polysomnography on them and have the technician dial up the oxygen as they need it. In her case, even though she has a normal bicarb, I might put a transcutaneous CO2 monitor on her and monitor her CO2 through the night as well.
Sure. So those are rarely available, at least where I work, and they're expensive.
Even in the US, they're not consistent.
Okay, because we would think that if the oxygen saturation is dropping, the overnight oximetry is a simple test, but we would wonder whether we have to get the patient back into the hospital for that. Can't that be done at home in situations where you could just get a simple night-ox machine or something like that?
Yeah, I think in this particular case, her oxygen saturation is pretty low. I mean, pretty dramatically low. I think in cases where the oxygen saturation may not be as severely decreased, sure. You could simply just say, wear your oxygen with your CPAP at night at 2 liters per minute, and then repeat this test.
Emerson, any thoughts on this case?
I'd be very curious what the patient's subjective experience was, Nancy, over the course of time, how she was doing beyond simply the Epworth score and some of her respiratory parameters.
Yeah, she, as far as her sleep goes, she was feeling pretty good. I mean, she didn't really have any specific sleep complaints. I mean, obviously her respiratory status had gotten worse. And so, she had become less active. But she didn't really have any complaints about her CPAP at this point in time.
Nancy, how was she feeling during the day?
Again, I think more of her complaints were related to her respiratory status. So, she was not as active, as I mentioned, as she used to be, and maybe a little depressed about that. But she wasn't excessively sleepy or fatigued per se.
Great case. It really, to me, it highlights why we need such a granular approach on the respiratory care side, if you will, or on the pulmonary care side, from an interdisciplinary care team perspective. We need to be dialed into the medical numbers.
I agree, Emerson. I agree.
So just to summarize a little with regards to this case, when you look at the prevalence of obstructive sleep apnea, it used to be thought that it was higher in patients with COPD, but subsequent studies have shown it's about the same as an age-matched population. However, these patients will tend to have more hypoxemia, as I mentioned, much worse in REM sleep. They're obviously more likely to have cor pulmonale. Usually you can get away with just adding oxygen, but if they have that REM-related hypoventilation, they may need non-invasive ventilation with like a bilevel PAP or an AVAPS. And as we've talked about, the utility of overnight oximetry.
Yeah, I think most chest physicians seem to even today lecture that OSA is more common in COPD, and they love to talk about the overlap syndrome, and you're saying recent data suggests that it's not more common, right?
It's not more common, but it tends to be, it's an important association to recognize for sure.
Sure. That I agree with. That's great. Fantastic. Thank you so much, Nancy. Enjoyed that case, really.